Okay, so it is with trepidation that I show my first innovation in pharmacology is actually a return to old things that have come back into vogue. I know that the moderator is a fan of bivalirudin, but I've come back around to heparin, just like the bean boots that I had when I was a freshman in college, or have now finally come back into vogue, and people are watching or listening to records again. So I think heparin's made a comeback, and I think there's a variety of reasons for that. Is because acute stent thrombosis is higher with bival. Ischemic events are higher with bival. If you're not using a 2B3A, heparin and bival have similar bleeding rates. In a contemporary era of radial and higher potency P2Y12 inhibition, the superiority of bival is questionable. So definite stent thrombosis, higher. MACE rates stratified by 2B3A use, not so different. Abrogating the difference advantage bival if there is provisional 2B3A use or planned 2B3A use. And a randomized trial looking more in a contemporary era of usual dose heparin versus bival in patients who are mostly radial and mostly ticagrelor, with a proportion, we'll talk about this in a few moments, a large proportion who are getting loaded on the table. And I think that's a missed opportunity, or loaded very shortly before their procedure, but no difference in mortality, no difference in myocardial infarction, no difference in bleeding events. So this is kind of what I'm talking about. You guys have seen this video of some of my friends show this, and it's something that we have as physicians is intentional blindness. We're looking at the LAD, but if you look through the LAD at the stomach, you see the 2 tablets of clopidogrel sitting there. And I have this feeling that they're not properly inhibiting the platelets at this point. And you see the 81 milligrams of aspirin that weren't chewed, they were just swallowed. And they're sitting there. And my own little gastric emptying study, you see when I finally got into the right, that one of the aspirins has moved into the duodenum. I don't know what the reimbursement is for a gastric emptying study, but it's probably better than a right heart cath. And also this kind of concept of, are we doing the right thing? So I think the innovation I want to talk about here is that pre-treatment is not really an innovation. That's kind of the best that we had before we had some of these other agents, is to give the clopidogrel as soon as possible. But now analyses have shown that there's not an associated reduction in death with pre-treatment, nor is there a reduction in major bleeding events. And in a non-STEMI population, there's a significant increase in TIMI major bleeding. And the reduction in MACE events is mainly driven by periprocedural MI, which is somewhat of a controversial endpoint. So to draw your attention to a newer pharmacologic agent that's available to us to fill in this blanking period without substantively increasing major bleeding events is the utilization of cangrelor in patients who haven't been pretreated, to help support the procedure and avoid, in most cases, the major thing we're avoiding is intraprocedural thrombotic events. Now, when these happen, we usually are able to deal with it as interventionalists. We'll rescue the side branch, we'll get the artery back open, and usually we're giving people high fives of how great that case was at the end. But there's a substantial cost associated with these events, and there's actually a substantial clinical import. So these are patients that Philippe Genero looked at and looked at the outcomes amongst patients who have intraprocedural thrombotic events. You can see the difference in outcome if you suffer one of these events versus not. And you can see also displayed in a different way the impact of intraprocedural thrombotic events or stent thrombosis on 30-day mortality. So now shifting gears to after the PCI, what are the pharmacologic innovations? So we're faced with a lot of patients who in one way, shape, or form require antithrombotic therapy and antiplatelet therapy after their PCI procedure. In this group of atrial fibrillation patients, my partner and friend and mentor, Mike Gibson, ran the Pioneer study and looked at a Woost-like group of patients getting rivaroxaban and clopidogrel only, no aspirin. An Atlas-like group who are getting DAPT and mini dose, baby dose rivaroxaban. and then people getting conventional triple therapy. And the primary endpoint was clinically significant bleeding events, and you can see that the rivaroxaban-based therapies have much lower bleeding with no significant difference, at least in the number of patients seen, and the duration of follow-up with the penalty for MACE events. I do want to draw your attention to something that I'm seeing very frequently when I am on the wards or afterwards is a major threat to our patients is the mix and match approach to triple therapy or these agents. We will do the PCI, we will do the best PCI that we can, we'll have a great result, and then the person will go to the floor and they'll have 5 minutes of atrial fibrillation and someone will start them on rivaroxaban because then they can discharge them the next day. And I just want to point out to you that this has been looked at, and full dose rivaroxaban with dual antiplatelet therapy is associated with a substantial amount of bleeding, and it can be fatal bleeding, it can be intracranial bleeding. So DAPT was with 5 milligrams of rivaroxaban for a reason, not 20 milligrams. And if you interrogate your pharmacy databases, you'll find what we found is there have been hundreds of patients discharged from our major teaching institution on, you name it, apixaban full dose plus ticagrelor plus full dose aspirin. Just people are making it up, and it's not something that I think is actually safe for our patients. Oops, sorry, going the wrong way. Just a brief thing, since we were talking about efficiencies in the hospital, utilizing these agents was associated with fewer rehospitalizations and obviously an economic benefit thereafter. Redual, similar kind of story in triple therapy, this time utilizing dabigatran at full dose or reduced dose versus conventional triple therapy, and the story is similar, that bleeding events are much lower. So also in your armamentarium can be utilization of dabigatran. And then I'll close with what I think will be innovation coming, Roxana, August 2019 will be Twilight. Reported Dr. Baber and Dr. Mehran are running this very important trial looking at, again, the innovation of taking things away rather than adding, and in this case, taking away aspirin and running only ticagrelor in these patients after coronary intervention or at high risk for bleeding. So with that, thank you very much, and I'll take any questions.
Thank you, Duane. I think there is, your points are very well taken. We are making some innovation. It is back to the basics, back to heparin. I think, is anyone using bivalirudin in the room as their go-to drug other than me? Okay, great. So it is back to heparin, and I think you're right about that. But less is more here, right? And I think it looks like we're withdrawing therapies, and with Twilight we're going to withdraw aspirin, and of course now we showed with triple therapy less is more. Any insight into this secondary prevention, into switching? I'd love to hear from Arnold and from you as well, all of you. I think there is a lot of confusion. The state of pharmacology is not an innovative one, but a confused state where there are multitudes of different permutations of the drugs and durations and dosing, and it's really, really confusing. How could we innovate there to make it less confusing and more user-friendly for our physicians? Arnold?
Well, I think you're on the right track by taking away the aspirin and actually rigorously studying that. I mean, that's an amazing trial to do, and something that we never do because we always just pile on new therapies on the old, because that's the easiest way to test it. I think that, Kirk, and you have it right when you say less is more. We've known that, shorter duration DAPT is going to be better. And certainly, I was asked the question before, on triple therapy, someone with anticoagulation, the 20% of patients after PCI who have AFib, these are patients where you really want to minimize that duration of dual antiplatelet therapy. And I'm suggesting just 1 month of triple therapy at most, or direct to dual therapy. And I think this is where less is more will clearly show a difference in benefit to patients.
I call it the tyranny of the Chads in the hospital. People are spazzed out about people having a CHAD score of 4. and you have to immediately get them on anticoagulation, when that threat over time in the first month is really about stent thrombosis for this patient and recurrent MI. It's not about stroke in the very short term.
But I think also importantly, you're not saying that not to think about stroke prevention, because our guidelines and the lawyers are waiting for that patient to have a stroke to come back after you. I mean, I think those are really some real issues. But I think importantly what you're saying is that think about what events are at what time best, and could something innovative like an innovative app or something to help physicians navigate this very difficult arena. Is that the next innovation? Yes, we want to be innovative in, like, you didn't talk about PCSK9s and all these other incredible new pharmacotherapies that are coming for secondary prevention, but where we are with antiplatelet and anticoagulant regimen is very difficult to navigate.
Yeah, I just wanted to mention in response to your comment about an app, just within the last month, the ACC has published an app that's at least a step in the right direction. Yeah. You've got it, yeah, that gives you information about how to stepwise get your patient back up to speed with their oral anticoagulant when needed, and when that drug has been interrupted for a procedure. And I tested it. I would say I found it somewhat useful. It's not a perfect app, but it's a complicated space and hard to, sort of like an electronic health record, you know, it's hard to make something that really seems as useful as you would like it to be. But I would encourage you to check it out. It's actually pretty interesting. And could I just say, can I take 30 seconds? I'd just like to ask the panel their thoughts about Adnexa, this new reversal agent for NOACs. Have any of you, where does this stand in your hospitals, may I ask?
My understanding is that it's not in wide release until 2019, and Fortola Medical just got their approval a few months ago, and they're rolling it out slowly, and that the projected price might be quite high.